Mm-hmm.
Thank you.
Is it going?
Yes.
Okay. So is that going to your cloud?
Yes.
All right. Okay, y'all. Well, so it sounds like we've got a mixed crew here. As far as some of you, this will be new, and some of you were there last time. Okay. Well, let us get started then. Everybody see this?
Yes.
Okay. All right. So today we're going to be talking about using ACT as a model for process-based therapy and a brief intervention. Those of you that were not at the last presentation, any exposure to ACT in the past? Okay. All right. So a quick review from last time where we discussed the research base for ACT, the foundational underpinnings of the model, defined psychological flexibility, and reviewed the 6 core processes that are really 3, that are really 1, that are all interconnected. And the previous invitation, which was your presence, an open heart, to have a reason for being here, and to hold lightly judgments, evaluations, and beliefs about what can and can't be done and how things should be done. To hold lightly self-stories of what you can and can't do. I'll invite you to be curious. And if you've been exposed to ACT, to bring a beginner's mind to the learning process. And just a quick sense of, is that something you all are willing to do and bring to our time together? Awesome, thanks guys. So our objectives are to describe how the psychological flexibility model that underlies the ACT can be used as a model for process-based therapy and a brief intervention. To describe how to use the contextual interview as a method of yielding clinically useful data. To describe how to use life context and problem context findings to read, formulate, and move psychological flexibility processes. So first, I'll describe process-based ACT. Second, I'll describe the FACT model. And then I'll teach you how to do a contextual interview and use that information to group. So why process-based therapy? The reason that the reason Steve Hayes kind of developed this new approach is due to changes in the funding structure for research. And so there's a movement away from DSM-5 and towards a dimensional versus a categorical approach. And so that kind of ultimately led to the development of a new model, a way to approach the work and research. Also for practical effectiveness and process of change, and to match how many ACT experts practice anyways. So process-based therapy is treatment based on the coherent application of changeable evidence-based processes linked to evidence-based procedures that ameliorate problems and promote the prosperity of people. So you'll see process-based CBT, process-based ACT. This is sort of kind of the new thinking, at least with Steve. And I have seen Kirk Strassel as well talk about it. I'm sure Kelly as well. So beyond protocols and manuals, these are good things. They tend to push people into places of the model that maybe they're uncomfortable with and could avoid. And if they're done flexibly and not rigidly, they are of value. Process-based therapy is moving beyond protocols and manuals and looking at contextually embedded processes that are changeable, and specifically processes that mediate treatment outcomes. And so if we're going to do that, those models need to be coherent, comprehensive, and broadly applied, transdiagnostic. So process becomes the outcome, so movement of a process, rather than focusing on techniques and symptom outcomes. No longer the case that techniques become the therapy, but rather a therapy that uses techniques. We want to know why and when to use those techniques. And the example here was that sometimes in ACT supervision, Robin would have people use a metaphor that would be often kind of misplaced and sort of done just because they should do it. They thought they should do it and didn't really even know why they did it. So being able to really know why you're doing what you're doing when you do it, to have it really match a process that is a kind of a potent process, one that has some leverage to it. So as part of process-based ACT and FACT, we will be learning to listen with ACT ears. So I'm not going to go through all of these in great detail because of last presentation and for time, but just a quick overview. We're going to be listening for inflexibility and rigidity processes. So listening for orientation towards the past and the future, listening for lack of clarity with values, and avoidance, behavioral avoidance, conceptualized self stories, cognitive fusion or entanglement, and experiential avoidance. And really listening to those are all reads that you can sort of listen for. We're also listening for the siren songs of suffering, the things that tend to trap people. So experiential avoidance, avoiding their internal experience, whether that be thoughts, feelings, memories, sensations, and behavioral avoidance, stopping doing the things that they used to do, the things that they care about. And then entanglement and fusion, lack of distance with their thoughts, and sort of kind of rule following, rigid rule following, lack of awareness of the process of thinking, obeying their mind and doing everything they think, which is sort of part of what happens to humans as part of like languaging. So we can listen for that. And then we can also listen for flexibility, and we can sort of support that. So listening for contact with the present moment, attentional flexibility, listening for values and awareness of that, and listening for behavioral flexibility and commitments, listening for perspective taking, holding self-stories lightly, listening for cognitive distancing, cognitive flexibility, listening for acceptance and willingness. So kind of also we want to listen below the content. So there's the content of what folks will tell you, and it can be easy to get caught up in the story and miss the underlying process. So we want to listen below the story and the narrative. We want to listen for the function of behavior. We want to listen for avoidance, or we might even see it happen in front of us. Listen for context. And we can listen to what that content tells us about what they care about, and what they're kind of emoting tells us about what they care about. So there's an overarching, ongoing process that's in motion. There's an interpersonal process, so what's happening between us, and an intrapersonal process, what's happening within you. And so we can bring awareness to all of that. So this is a kind of a diagram that sort of shows you all that's happening in between. There's lots of moving targets that you could go for. So whatever process you are reading, there could be several that are happening. But at the same time, you're bringing your own psychology to the room. So you are impacting them, and they are impacting you. And there's a bi-directional mutual shaping process. So we want to kind of notice how they're shaping you and how you are impacting them. We want to watch for new behaviors happening that add variation and broadening of behavioral repertoires. So intrapersonal process, what is happening and flowing within you, and how can you use that in the room from an open, aware, and engaged space. So you want to be sort of connecting with the movement, the motion, and flow of experience that's happening. In awareness of ourselves and our own thoughts and feelings unfolding, this gives us an opportunity to model willingness and to get our own hearts in the room. It gives us an opportunity to model, to instigate, and support psychological flexibility in our clients or patients, and to embody the work in your presence. And in service of the client, self-disclosure is a core competency in ACT. So we need to be aware of ourselves, and also to, if there's an opportunity to model a process, being willing to be a fellow human, that you are in the same soup of humanity and language. And so, always in service of the person, not for you. It's usually shorter and not the big, long story. So you want to be aware of your own willingness to sit with their pain. If they sense that you are unwilling, they may rescue you. And so, being very open to not being rescued, to walking through and to staying with that feeling in service of some sort of liberation. And so really, in terms of intrapersonal process, we need to be aware of how their story is affecting us. And then, are we open? Are we aware? Are we engaged in doing so? We want to be aware of the balance during this interaction. So if there's too much of one, then there's an imbalance. So, for example, if the client or patient is talking for 25 minutes straight with not a breath in between, we want to be compassionate with that. If there's only 30 minutes for the visit, then there would be an imbalance. So, and if you're talking the whole time, same thing, sort of you want to try to keep a balance there. And if it's a ton of intervention, like if you do a mindfulness exercise for the whole session, where they don't get to talk much, or you don't get to, so you want there just to be harmony there, to be at least mindful and aware of it. Only way you're going to catch that is by being aware. So before moving on, I want to get some questions, or I want to see if there are any questions. If not, that's okay. I just didn't want to be charging forward and not give you guys a chance to ask about what I just said. We good? Okay. All right. So why brief interventions? So this is why Focused Act was developed, was really for treatment contexts changing, so for example, primary care, behavioral health, I work in primary care, but there are other kind of areas of work where it's a briefer course. And on top of that, even in traditional settings, there are going to be some that don't do the maybe prescribed 12 visits. And so the idea here is that our ability to predict behavior change and treatment response is poor, and that even patients with chronic problems could suddenly make changes with minimal or even no assistance at times. That when you look broadly at all the different settings, the mode is one. Many will come just for one visit when you look at all these different settings, and that oftentimes they will go until the distress has dropped, which is often by visit 5. And that oftentimes they won't even consult their therapist before terminating. And that those that drop out is usually by visit 1 or 2. So the rationale was, okay, if that's going to happen for a kind of proportion of the patients or clients, then if we do a big lengthy interview with no intervention at all, and then that may have been our only shot. And so what if we changed the game and how we do things, and then try to treat that visit as if it could be our last, but hope for 4 to 6. And so that's sort of why this was developed. This model was developed. And in primary care, when you also look at sort of what happens, so there are going to be a lot of folks with mental health concerns who never even make it to traditional mental health, but they go to primary care. And what I have observed is that of those with mental health needs, there will be some, like a percentage of those, that if they get referred to traditional mental health, they will go. Or even to see me for a behavioral health consultation, they'll go. They'll make that appointment if it's in a week. But there are going to be some that they'll see you, but only if you catch them right then in the medical clinic. And then there are going to be some that just won't do it. They're just because of stigma and a variety of things, they just won't do it. And occasionally, if I meet them, I'm not what they thought I was. And it feels a lot less judgmental, accepting, safer. And then they'll end up talking to me, and you can just see their defenses sort of relax. But, so in all of these settings, if you think about all of the people that never even make it to traditional mental health, those people, you may see them in the clinic, but you may just get that one shot. So the idea was to develop a model that can work briefly. So also there is sudden gains research, where some will be rapid responders, and that it's not always just a quick gain, but then it immediately sort of kind of returns back to a baseline, that there are some that do make sudden gains with a variety of different problems. And so being aware that, our ability to predict is not always great, and that sometimes people can surprise you. If some functional change happens, then you can see a change rather quickly. The saying in Focused Act is that, when people stop suppressing and stop checking out of life, they often get better. And so when you sit with people, you can be aware of that they can be a rapid responder, and to be open to that possibly they could be. Maybe not, but they could be, and even being aware of that. Also, too, the dose effect, that oftentimes the vast majority of gains happen by visit 8, and that in order to get to like kind of a significant, movement beyond that, 8 to visit 26. So sort of, the idea being that let's try to do a lot within 4 to 6 visits during the time where people, the natural breaking point where people tend to drop out anyways, So why FACT? It's transdiagnostic, broadly applied. It's brief, focused on functioning rather than symptom reduction, and focused on strengths. So the kind of pillars of psychological flexibility. So earlier on, I mentioned 6 processes that are really 3 that are really 1, which is psychological flexibility, but it's all interconnected. So, so open, aware, and engaged, or closed, checked out, and lost. And so those are sort of the pillars that are kind of described in the FACT model. In the original, or the second edition seminal text, it was described as open, centered, and actively engaged. Russ Harris has a different kind of a triangle, but they're all sort of have some similarities. So FACT is focused on functioning and barriers to functioning related to rule following. So that being a barrier to functioning. So rigid rule following, cognitive rigidity, emotional and behavioral avoidance. Teaching people to accept the presence of distressing, unwanted, private experiences that function as barriers to workability. Choose a life path based on personal values rather than avoidance of pain, and to take actions which propel them down that path. So that's sort of the spirit of the work. So we'll be doing a contextual interview, a functional assessment. We're going to be contextualizing the problem and yielding a behavioral experiment that moves from experiential avoidance to name and notice, from behavioral avoidance to actions that reflect your values. We'll be treating every session as if it could be your last. You plan for 1, but hope for 4 to 6. So what ends up happening is a series of single session interventions, trying to get the maximum impact out of each session. There's no assumption on time it takes to benefit. And you speak in rapid change terminology. So what's suggested here is that if you describe this is going to take a long time, then they may fulfill that prophecy. But if you speak in rapid change terms, then you might change the trajectory of the work.
Could you provide an example of like the difference between like rapid change terminology? Like what would that like sound like?
So for example, when you introduce I'll go through an introduction with you all, but when you describe that, like some people get what they need in the first visit and they don't need to come back, you're setting the stage that this isn't going to take a lot of visits versus saying, kind of at the end of the visit, telling them that it's going to take however long. You're sort of not assuming that it's going to take that long. I normally will describe that I usually see people for 4 to 6 visits on average. And that, but some people see me just the one time. And then I'll talk about sort of like if certain changes are made, that people can get better quickly, and to be open and curious to that, and then have them notice if there is a sudden gain that does happen, and then having them really be active in between visits, like to really apply. So the vast majority of the work is happening between the visits, and then have them be curious about how that experiment went, and have them notice, did life open up or did it narrow and shrink? But being mindful of, any language that indicates that this is going to take a long time. I don't speak in those, I haven't spoken those terms in a long time, so I don't really recall the types of things that we sometimes say that indicate that things are going to be chronic, and that, I'm sure there are lots of good examples for the, the counter belief. But is that helpful at all?
Yeah, that's helpful. It kind of reminded me of like when people say like, oh, it's going to get harder before it gets better. And that's just, that like to me makes it seem like, oh, well, this is going to be like a long process. So that's kind of what I was thinking would be like on the more longer term kind of terminology that I've heard people use before. So
yeah, that's true. I've heard that as well. And it's not that there's anything wrong with that. It's just different. So this is a model, and so it's not to insult or challenge. It's just, okay, so if you open up your mind to what if they were a rapid responder, and if you kept that door open, might that, just being curious, what if that made a difference? And then you as a therapist can then experiment yourself in talking in rapid change terms, and then just observe what happens, and then just even thinking through, do my beliefs about how long it will take fulfill any prophecies? I don't know, but just be curious. So getting anchored for the work to be done. All right. So our goal is to listen with precision, scope, and depth. So we're looking to grab slices of behavior in the space between and working with those in the present moment space. Read a process and open the door to a process. Now, just because you saw one doesn't mean that's going to be the one you go for. I'll describe later on how the contextual interview is like a dental exam. So just because you saw it doesn't mean that's going to be the one. But you can listen for these processes and then use a technique or method, all while maintaining the space and relationship. So getting centered, we want to be aware of ourselves, aware of the other, and the betweenness of the work. And we want to model. So aware, centered, open, and engaged. Sunset mode of mind, not a math problem. So this is Kelly Wilson's kind of way of doing things is, viewing the person as a sunset that you would not fix or problem solve. You just observe. And whereas a math problem, you try to fix it. And so, kind of stepping back and being aware of the person before you and sort of what's happening in terms of not just content, but viewing them as a sunset. And remember your mindset. Be curious. What if this was a rapid responder? It's a really interesting thought. When Kirk Strassel said that, I remember thinking, huh. And I remember I did those webinars they were like on Wednesdays from like 1 or like noon till 2. And then I would get done and go practice. I would like walk out of my office and go see patients. And I remember being curious about that. What if they were a rapid responder? And I still do that. They don't always, but sometimes they do. Now, the Therapeutic Posture and Act. Assume that dramatic, powerful change is possible and possible quickly. So check that out. That fits, right? Assume that this is Steve's, by the way. This is like Steve's kind of information. But so assume that dramatic, powerful change is possible and possible quickly. Whatever a client is experiencing is not the enemy. It is the fight against experiencing experiences that is harmful and traumatic. You can't rescue clients from the difficulty and challenge of growth. Compassionately accept no reasons or explanations that are unhelpful. The issue is workability, not reasonableness. When in doubt, ask yourself or the client, what is this in service of? If the client is trapped, frustrated, confused, afraid, angry, or anxious, be glad. This is exactly what needs to be worked on, and it is here now in front of you. Turn the barrier into an opportunity. If you feel trapped, frustrated, confused, afraid, angry, or anxious, be glad. You are now in the same boat as the client. If you open up to it, you can humanize your work. In the area of acceptance, diffusion, self, and values, it is more important as a therapist to do as you say than to say what to do. Instigate, model, and support flexibility processes by embodying them. That is something that I really have made a mission of mine, is to do as I say rather than say what to do. Perfect, no. Aim, yes. And so just as a quick check, think through like if you were a client and your therapist embodied these, imagine sort of how you might experience that, to have somebody that embodied these qualities as they sit with you. So setting a context for the encounter, model, instigate, and support. So being present, accepting, including willingness to feel what is there to be felt and not rescue, non-judgmental, care about what they care about, engaged during the time we have, and practice perspective taking. So these are all qualities that you can bring to each of these single session interventions, at least in the ACT model, but in any process-based therapy encounter. So getting started. So in fact, the introduction includes your role. So you describe what your role is, and then what to expect for the visit. And so what I describe is I'm going to ask you a lot of questions today to get a snapshot of your life. And then the possible outcomes, one visit, on average 4 to 6, and we're going to have 20 to 30 minutes today. Now, that is primary care. So you're going to have more time than I do. And so, but there's no really expectation here on how long it has to be, so, if you go a little longer, then they may not need to come back, and then the goal to be helpful and to make this problem better for you. And then other informed consent elements that you may have that are required by your agency. So then the biopsychosocial interview is the problem context interview and the life context interview. So the problem context, this is your functional analysis of the problem. So in fact, it's described as the 3 T's: time, triggers, and trajectory. I will give you all my slides, so you're going to have all the questions. And I've also I'm going to give you a bundle of resources that has a contextual interview that I give to my supervisees that you can experiment with. You can, fill it out as you go if you want to try it out. But I want to give you all resources so that you can, if you like this work, you can experiment with it and just see, is it life-giving for you? And most importantly, life-giving for your clients. Looking at the functional impact of the problem, what do they deeply care about that led to a pain like this? That question is probably at the top of my list. I want to know that. Treatment history in the past, what have they done? Have they ever had any type of counseling or psychiatry? What have they tried to solve this problem? How has that worked? So the questions are here. Again, these are all going to be in the slides and in the resources I give you. And so just getting a sense for time, triggers, trajectory, and then also how big of a problem this is. And then the life context interview is workability first. But the life context interview is going to tell you a little bit about how it's impacted their life in different domains. So what are they seeking and how would they know they're improving? So this is going to tell you the control agenda. They want it to be gone, the feelings to be gone a lot of times. And what have you tried to solve this? And how has it worked? Now, this is in a non-judgmental, curious type of way. Not, well, how has that worked for you? Not like that. Gentle, kind, curious. How has what you've tried worked in terms of what matters to you? Does it bring you closer to the life you want to live? And then the life context: love, work, play, and health. So we're going to assess relational health, engagement or lack of engagement with social support, communication skills. You'll kind of uncover this a lot of times, what home is like. And sometimes, sadly, we can't rescue them from environments sometimes, like it's a maintaining condition. It's sometimes not immediately modifiable. Work and school functioning, and what do they enjoy, and are they engaging those areas of life, or has that stopped? And who and what does this person care about? health behaviors. This will give you a sense of kind of how, what their lifestyle is like. Do they exercise? How is their sleep? Are they eating okay? How's their nutrition? Do they use tobacco? What's their alcohol use like? Substances? This is what I'll kind of an example of what I'll be giving you all to help guide that part of the interview. So in terms of a dental exam, think of this like, you're poking and prodding for pain, not an aggressive type of way, but like watching for what hurts. But you don't want to stop at the first tooth. You want to finish your exam. And so that's why you may have lots of reads, and but you want to pick the one, okay, if I never saw this person again, what would be the one that would be the most potentially life-giving? So the order is flexible. Different providers have different preferences. The interview is meant to be conversational, and kind of what the point is to put the problem into its context. As far as the order goes, I sort of switch based on what the need is. So sometimes, like if I sort of get a sense of what is it that brings you here today, and it's very vague and they don't really know why they were referred to me, I may start with the life context interview first, and that sometimes will emerge the problem. It'll bring it out. Or if like in primary care, sometimes I'll get a physical complaint that doesn't have a clear, like the problem, why they're being referred to me. They may not even really, like I'll give an example a little bit later. I'll explain it then. Okay. So I'll hang tight. But basically, context for the visit will determine sometimes the order of which way I go. So here's what I want to know at the end. If I don't know this, I notice that I don't know this. And sometimes I will even kind of pull these up and at the end of a visit, sort of see if I can't try to get a sense. So what are they doing to address the problem? How are their solutions working? Has life expanded or narrowed? What matters and who matters to them? And what might they do in a world where anything was possible? So those are all things that would be lovely to know at the end of the contextual interview. Also, some additional contexts. So really everything that influences the behavior being analyzed. So there's like, 3 different contextual layers here. There's the external, internal, and then their relationship to both as a context. So externally, their relationships. So at the end of the contextual interview, do you have a good sense of their environment, their relationships, their culture? At the end of the interview, do you have a pretty good sense of their teams, which I'll describe shortly, their substance use? You're not going to know necessarily their genetics and epigenetics, but that is in an internal context. Developmental learning history. These are all influence the behavior being analyzed. And then relationship to both. How do they relate to their external and internal worlds? How their behavior is functioning, and what are the maintaining conditions. So context is vast, nonstop, and it's very complex. So by this point, you should be able to provide a summative statement once you get to the end of the interview and be able to match a behavioral experiment to the psychological flexibility process you have identified in the interview, or the tooth. By the end of this interview, you may find an intervention drops in your lap. So hopefully you have a pretty good sense of the locus of pain and how this is linked to their values. What do they care about here that makes this hurt? Open the door, open the door to a process, apply a method, and design a mutually agreed upon plan to implement between visits. Get their response and their agreement on that plan. And then observe whether a process moved in front of you and upon their return, if they end up returning. Sometimes you can watch it move in front of you. Like, for example, you can see them move from a closed heart to an open heart. You can see them get a little bit of distance from their thoughts. You can totally see it move. Anyhow, at times, sometimes you can. And that keeps me going and adds passion whenever I see life open up. So a behavioral experiment is a plan that identifies a specific action a patient plans to implement in order to observe its impact on the problem of concern, or more broadly, on their ability to live the life they choose. So notice, observe its impact. So with an experiment, you observe its impact. So characteristics of those experiments: approach versus avoidance, and like behavioral variability. Because remember that oftentimes, because of avoidance, life gets very narrow, very constricted. Life gets smaller because in order to control and keep this feeling away, there's a shutdown process, a checking out that happens, and trying not to elicit pain. And so we're wanting to look and see if we can't start to begin to open life up, even if it means there's feelings to be felt. In terms of modifiable context here, we can modify the way they feel that. We may not be able to take the feeling away, but we can modify the way they feel it, and empowering them to be able to feel what's there to be felt and to know what they know. So at the end, we can ask them, how confident are you that you'll do this? And if it's anything below a 7, you probably should design a smaller experiment. And just something that they're going to do, something that they'll do. And then ask them how helpful. Now, this was something that I didn't immediately buy into, but I started to do it as an experiment myself just to see. So how helpful was this visit? Sometimes people will give you the socially appropriate answer, but other times they'll tell you, that was a 4. So that tells you something about the therapeutic alliance. That tells you something about sort of whether you shot and hit a swoosh or a brick. So I asked the question at the end to rate how helpful the visit was. Putting all this together, the CARE model. So if you think about it, by the end of this interview, do we know the context? So behavioral avoidance creates lack of contact and gaps between patient needs, wants, and life outcomes, leading to symptom distress. Like, has that become clear? Avoidance, behavioral avoidance is under control of emotional avoidance rules. Paradoxical result is an increase in the need to avoid. Result is a spiral of more symptoms of distress and increasing dominance of avoidance. Reframe. Rules supporting avoidance are either recontextualized or replaced by rules supporting emotional acceptance and approach behaviors. For example, openness and engagement. An experiment. Value-based approach behaviors increase positive emotion feedback loops, increasing persistence in approach, even in the presence of distressing, unwanted private experiences. So that sort of gives us something to aim for with this work. All right, before we move on, questions. Okay, good to go? All right. All right, so beyond the first session, so really what we're, again, hoping for 4 to 6, and then try to get our work done by the natural breaking point. And so each one is going to be a single session intervention. Start with an outcome measure, and then follow up on the behavioral experiment, follow up on the problem. Is it same, better, or worse? And then get an agenda for the day. Now that agenda, especially if you're in a setting like mine where you only get 30 minutes, that can be helpful because it can sort of, rather than focus on something and then find out that there was something else and then you find that out right when you're about to close. So sort of a doorknob last minute discussion point. So trying to get an agenda on, what are the things you want to make sure we make time for today. And then we're going to group, which I'll go through here shortly, for a single session intervention, and then create a new behavioral experiment that has those same qualities that we went through earlier. So some of the outcome measures, I have saved these in a file for you all. The AAQ measures experiential avoidance. And then there are some other scales that are interesting that measure not symptoms, but coping strategy use scale. And then from positive psychology, the flourishing scale. And then there are also some values-based questionnaires by Kelly Wilson. And then there are a couple of fact assessment tools that you wouldn't give to them, to your client or patient, but that can sort of help you. So this is the pillars assessment tool, which allows you to sort of go through all of these different processes and look at what are their strengths, their deficits, and the targets for the work that you might do. So especially if you feel a bit lost with somebody, this could be a useful tool. Like when you're trying to decide, okay, what would be a useful next step. And then the Foursquare tool, which is similar to the ACT matrix. And so basically you have a way to look at, what are the actions that they're taking, or, what actions would promote flourishing and approach towards values, and which ones promote avoidance and control. And then what are the thoughts and feelings that tend to promote the avoidance and control. And then over on the bottom right, you might list sort of values. So grouping. So at the beginning of a process-based ACT encounter, get yourself centered, and then read and formulate key processes. Open the door to an area, use a method, and then purposefully recycle based on impact. So a broad array of interventions are available to you, drawn from protocols and research, and matched to a process that matters, that has functional importance and expands life. And then you're doing that not because you're supposed to do the exercise, not at weird times, that there's no clear rationale for introducing that. So how might we move it? So you can use the clinical conversation as a way to move process by asking questions that might move a process, by modeling it yourself, experiential work, and then the behavioral experiments. Listening with ACT ears, listening for values, also found in their pain, listening for the pain of presence, what's here now that hurts. And then the pain of absence, what's missing that's deeply cared for, that in its absence that hurts. And what content are they avoiding? And what have they checked out of? And did those things matter? And what would they have to feel in order to re-engage those? And then do you hear any sticky thoughts like, can't, never, should, must, always, forever? Do you hear self-related content, perspective taking, future, past oriented? These are all things you can really listen for, just to give you some examples of, okay, well, what would this look like? Also a variety of fact-based tools. This is one that I made that's a little bit expanded. It builds in some like polyvagal theory questions as well. But this is a way for people to be aware. You can give them this, and when they're at home, when they're kind of experiencing hard thoughts and feelings, it can give them a chance to get some distance, and ask them questions that might promote distancing, awareness and openness. And then even to go through this would be an act of engagement, because you would have to do that. And then once a person learns these questions, they don't have to look at the questionnaire anymore, or look at this anymore. I've given you all this as well, by the way. The life path and turnaround worksheet. So this is a lot like in the matrix, moving towards or away. And so this is just an exercise that you can do with them to kind of explore what more meaning might look like, what more control might look like, and to sort of prompt them to possibly do more approach and openness. And then the True North worksheet is similar. Just a metaphor you can use to kind of promote these processes. And again, that one's going to be in your resource packet. And then the bullseye activity as well. This is a way for you to kind of see how consistent their behavior is with a chosen value, and then to come up with an action plan that might promote movement. And here's another one that is similar to Kelly Wilson's Valued Living questionnaire, except for it's just boiled down to these domains of love, work, play, and health. And how this past week, how consistent have they been living with that? Not in a shameful type of way, shaming them for disengagement, but in a awareness type of way that might inform goal setting, behavioral experiments. And in that area of life that needs attention, love, work, play, or health, what and who matters, and maybe you'll make a plan. So thinking through, all right, how might this look if you decided to open the door to openness? Inviting them to practice an open heart versus a closed heart, which is a different language than acceptance, but it's a similar functional meaning. And that's how Kelly Wilson describes it. Using metaphor, like the quicksand, the Chinese finger trap, riding the wave of emotion, and experiential work, inviting them to lean in, make room, and open up. You can do body posture work that promotes openness. And then humanize them. linking their values and caring to their pain. And then self-compassion work. And then in terms of the thoughts, you can do any of the cognitive diffusion work as well. So any of this stuff that's in the ACT work that you would be familiar with, you're able to do any of those things that all in service of trying to move a process. So if you pick any one of these, like for example, the milk, if there was a really sticky word that was totally bullying them, then you could do that exercise with them. So that would be a purpose. You notice that word, they're avoiding that word. And so if you choose to do that exercise, then the idea would be, did it move distancing, cognitive distancing? Or if you hand them a dried flower and there's like a thought about them and, a sticky thought about them, what if they were invited to hold that lightly and then actually stick that dried flower in their hand and have them hold it? So any of those exercises matched to a process. And then engaged, can they turn towards rather than away? Asking them questions like, what would you have to feel in order to do that thing that matters to you? Would you be willing to do that thing that mattered, even if you had to make room for that feeling in doing so? Would you be willing to feel that if it meant you could do what matters here? Could we start with the smallest step linked to your values? So you can see how you can use the clinical conversation to try to move a process. Awareness and centering. So, using the 5 senses to help them get back in the here and now. And noticing when the mind is in the past or the future. Being present to be able to notice and name your experience. So being able to describe, to give your feeling a name, rather than it be vague, like stressed. But what is that feeling called? And, to be able to describe a thought, I'm having the thought that I'm not good enough. And being able to describe their teams. And then the serenity prayer can be a meditation that can sort of be used as a way to sort of center people. So they're all interconnected. So in order to accept, you need to know what you're accepting. To know what you're accepting, you need to look, to turn towards. When you look, it may benefit to look with curiosity, openness, acceptance, and love. And to give credit, that's from Dan Siegel. When we look with those eyes, you may see your values. We hurt where we care and care where we hurt. You may also see things you have stopped doing as to not evoke the pain you are looking at. And with enough distance, you might be able to witness your pain as the observer of your experience. You might also be able to look into the eyes of a younger version of yourself and say, I know. And you might be able to notice that version of you looking back and notice yourself being noticed. And from that space, perhaps some kindness can be offered. So anytime you open the door to a process, others will be visible, if you notice them. So as far as what this might look like, just a couple of examples. So if you ask somebody, what do you enjoy doing? And they say, I don't do anything anymore. I just sit in my room all day. Is there anything you used to do that you stopped doing? Well, I used to love cooking. So values. But that is something I used to do with my mom. Again, values, because you care. Ever since she died, I can't bring myself to do it. I just can't. It's too much. So, what are the reads? So we could read a lot of stuff. So you see how at the bottom I've got contact with the present moment, acceptance, diffusion, values, commitment, self as context. Anybody see any reads? Anybody? So there's two. Gosh, there's all three siren songs there. So remember, there was experiential avoidance. So avoidance of what might be felt if you cooked. Behavioral avoidance, not cooking. And entanglement. I just can't. It's too much. So that's verbal dominance of behavior. So there's a few reads. And there's values there. Make sense? So, and then we could look at self of, sort of what's my identity now that mom's gone, identity as a daughter, and that could show up in this work as well, so there's lots of opportunities within that little nugget there. Another one, I need to start keeping better examples, but this is one from last week. You are welcome, Joey. But I had this, hopefully the examples are helpful to you all. I had a patient who has a long history with a local mental health agency with schizoaffective disorder, and she gets a counseling visit every 3 months and sees psychiatry and gets medicine, and generally feels like the counselor is overworked and just doing just the bare minimum to, when they have their visits. Feels alone and really, really wants a baby, and has been to the ER once, been to primary care now the second time for pregnancy confirmation, and wanted, when the urine test was negative, wanted a blood test. And so I drew a big heart on the board and wrote alone and parent. And yearnings were to belong and to be a parent, both things that mattered a lot. And there was a thought there. Well, maybe the urine test was wrong. Maybe the urine test was wrong. And that maybe was super sticky. And so basically, when I drew the heart up there and pointed out that she cares a lot, and that in order to not feel, she would not have to not care. In order to not feel here, which was sadness, so she was able to notice and name the feeling here is sadness. In order to not feel sad, you would have to not care. And she just sort of relaxed into, you could just see it sort of melt away. And you could tell, the tears in her eyes were very kind. I could tell I saw a process move. Ultimately, at the very end, we settled on holding lightly the maybe. If her wisdom told her that that was the truth, and then holding in kindness the sadness. And so that's where we left off. But just to give you an example of sort of what it's like to, I started off with a life context interview with her because she was referred to me for the pregnancy confirmation issue. And I still really didn't know much about, all right, well, what is the problem here from her perspective? So I don't want to assume a problem. So I went with life context first, and all the rest fell into place. Okay. So 10 minutes. All right. In closing, be curious about what we believe. If we believe several sessions are needed, that they want longer sessions and more sessions, and can a meaningful encounter with precision, scope, and depth occur in 20 to 30 minutes? And to me, that was very life-giving when I realized that by watching Steve Hayes do process-based ACT during live real plays at a workshop, and then making us practice them. That a lot can be done in 20 to 30 minutes if you really sink in to the work. And then also, would you be willing to do that? You know, would you be willing to sit with that feeling if it were you? So that ends our presentation. So any dialogue is certainly welcome.
So I want to say thank you to start. And then you had mentioned in an earlier part of the presentation how some of the rapid resolution can occur for clients and that rapid change.
Mm-hmm.
Is that similar along the lines of the new techniques that they're teaching of rapid resolution therapy? Does this go along with that?
You know, honestly, I haven't looked into that. So I would have to do some homework.
Okay.
Yeah, I haven't seen the methods. I've seen like that they're researching, trying to predict who the rapid responders will be, you know, so.
Okay. Did anybody else have any questions?
I really liked the one part where you just acknowledge that it's okay to be stuck in a session and to own that, because at first I thought like if I was stuck, you know, like you need to try to figure out something so the client doesn't know. But when I actually did own that in a session, it really helped move the session forward. And so I like that you had mentioned that.
Whenever I feel stuck, I find it's helpful to do a matrix. And I actually prefer the upside down matrix so there's an original ACT matrix, and then there's one that Kelly Wilson does that's a metaphor, where the thoughts and feelings are birds and your values are the seeds or the garden, you know, and, you know, your commitments are, they are kind of the actions that produce the kind of crops. And so, but there's an upside down matrix where basically, I'll show you real quick. Well, here we go. So one of the forums I'm going to give you all has it on there. So basically, you know, it's reversed on the traditional matrix. Everything that's the internal world is below, but Steve flipped it to head and heart and hands and feet. So basically, Values go up here.
I think you have to reshare your screen because I still see your files.
Oh, okay.
Yeah, Zoom's weird.
Thank you. Yes, there we go. You're right, though. Okay, got that?
Yes.
Okay, so head and heart, and hands and feet. So the top right, head and heart is values. So moving towards, that's what the person cares about. And then the bottom right, what are the actions that are moving towards? And then the left side, head and heart, this is where all the teams are that tend to pull them towards avoidance. So thoughts, emotions, action urges, memories, sensations, and then RGBs is rule governed behaviors. And then the bottom left is hands and feet. These are the avoidant behaviors. And then you find out that they're in a loop, that they're spending all their time on the left side. That can help you once you become aware of their values and what valued living might look like, then that can help to orient you a bit. So you'll have that. And then as far as research goes, let me find. You all seeing this right now?
Yes.
Okay. Let's see. On my last slide, I put together all of the categories like research support, strongest research support, but I want to show you this other slide real quick. Okay, so RCTs, so it took 28 years to get to 100, but then rapidly 4 years to get to 200, and then to 300, 3 years. So they're just kind of rapidly happening. And then this is sort of the list of a variety of different studies so it's meant to be transdiagnostic. And so this will give you kind of a sense of sort of what has been researched so far. As far as the strongest research support, I'm probably going to have to change the screen share again. All right, here we go. So back to Zoom, stop sharing that, and then share this. Okay, got it?
Yes.
So that's sort of the kind of like when you look at APA Division 12. So strongest data for anxiety, depression, substance use, chronic pain, and then transdiagnostic groups. So obsessive compulsive disorder, modest research support, chronic pain, strong, depression, modest, mixed anxiety, modest, psychosis, modest. Any other thoughts or questions?
Bree Williams had put in the chat, what population does ACT work best with, in your opinion?
Oh, in my opinion.
Yes.
Okay. I feel like it does really well with anxiety and depression, which is the vast majority of what comes in the door a lot, and I think that there are some shared qualities with motivational interviewing that lends itself to substance use work as well. And also, I would agree on the chronic pain. I don't know. I mean, I think that transdiagnostically, it helped. I just generally find that it's a good frame for just sitting with people as a fellow human, looking at them in a, not necessarily in a pathologizing way, but looking at the adaptive functions of what's happening. And so it's very humanizing to me to sit with people and view them through this lens. And then in ACT, the thing is you can use evidence-based approaches in the model. And so, you can, whatever, CBT approach is, you may not approach thoughts the same way, but you can still apply all the same interventions as appropriate. So I don't necessarily feel as though one is favored more than the other. For me, the hardest, the time where I struggle the most is whenever rigidity is so sturdy. Like the rigidity is so sturdy and the willingness is so low. What you could call help rejection, just very low willingness, and the cognitive fusion is just so sturdy and not budgeable. That's where, sometimes I get stuck. So, very welcome. Do y'all have any other thoughts about sort of like how you might use something from today that might inform your work, like anything you might experiment with? Like if you think about, okay, if I were to just take something from today and try it out and just watch what happens, is there anything that catches your interest?
Something that stuck out to me, and it's something that I guess I've been kind of aware of in a peripheral sense, but you really simplified it in a way that it was like, oh, that's what that is. The concept of something hurting, like what we value is where it hurts. A lot of what you've presented today has felt really familiar and has really resonated with me. Most of my work has been within eating disorders, and I'm recognizing a lot of the same themes of just sitting and being present, going into a lot of the self-awareness and mindfulness pieces of trying to cultivate that connection and start moving towards approach instead of avoidance. Not quite as much the rapid response, at least I worked in residential, so we weren't typically working with a population that was going to really work well for, but a lot of the other concepts, we use a lot of that. So, I mean, I've really appreciated how you've presented it in a way that it's been very clear and very direct.
Awesome. Thank you. Thanks for that feedback.
I know for me, since working with you, I incorporate people's values more and ask them to define what they're doing that's outside of their values, so we can work on that. And of course, pointing out their sticky words.
We've all got them.
Yep.
Okay. Well, listen, you all, thanks for showing up wholeheartedly. And if ever you need anything, I'm at Christ Community Fraser. And so, I'm always interested in fellow people who like to geek out and learn and serve. And, so feel free to holler, if ever I can be of service to you. And I'll send out that bundle of info to Joy, and that way you guys can have some tools that you can experiment with. Feel free to circle back at any time. Joy, you're welcome to pass on my email in case anybody ever wants to reach out. Okay.
Perfect. And I did put my email in the chat for anybody who wanted to send me a message to get the slides and stuff from today.
So here's mine. If anybody needs my info, very welcome, y'all. Yeah, I'll send this stuff out and go forth and enjoy and be curious. So
And thank you all for coming today. All right.
Yep.
Have
Thanks,
a great
y'all.
weekend.
Should we stop the recording?